without further ado, I'd love to introduce, we have two speakers today presenting for us. We have Tori Reagan, who's a graduate assistant athletic trainer at Montana State University, and Cassandra Lammers, who's head athletic trainer for West High School in Manchester, New Hampshire. And they are here to talk to us about some research they did over the past couple of years. So Tori and Cassie, welcome, and it's all yours.
All right, thank you guys so much for having us. We're really excited to be here and presenting our research. Hope you guys enjoy. And thank you to NVU for inviting us. This has been a really cool opportunity. Before we get started, just a quick shout out to our co-authors, Nora, Laura, Amy, Tamara, and Kaylee. Without your guidance and your input throughout this research project, it certainly would not be where it is today. And we really think we've created such a great component for athletic training. So just a little bit of background on me. I got my bachelor's degree in athletic training and kinesiology from SUNY Brockport. And while I was there, I got my first taste of research where I studied the psychological factors that affect mentality after injury. And then I went on to do my master's in exercise science at Adelphi University, where I was a graduate assistant with the volleyball team and the soccer team. I was also able to do some research there, but unfortunately COVID kind of interrupted that a little bit. But then we moved on to the residency at New Hampshire Musculoskeletal Institute, where Tori and I did this research. And now I am the head athletic trainer at West High School in Manchester, and it's been a great ride.
So I'm Tori Reagan, and I got my bachelor's of science in athletic training from Ithaca College, and I finished there in 2017. So I'm currently in my 5th year of being certified. And I started my first 3 years working at the secondary school level. My first year, I was an assistant at a boarding school called Hebron Academy in Maine. And then the next 2 years, I spent as the head athletic trainer at Gould Academy, which is also a boarding school, like 40 minutes down the road from Hebron. And then, like Cassie said, last year, we were both at the New Hampshire Musculoskeletal Institute. And now I am at Montana State University in Bozeman, Montana, working with the football team. And I'm getting my master's in exercise science. And then in my free time, I like to go hiking with my dog Oakley, and I really love to ski. That's why I moved out to Montana. So what is athletic training? In case you don't know, which I heard you guys had an athletic trainer come the other day, so maybe you do. But if you think of personal trainers or physical therapists, you might get this kind of look from an athletic trainer. But if you think of someone that runs out onto the field when someone's injured, or in the clinic helping them get back out onto the field, then you would be correct. So there's 5 domains of athletic training, and those include injury, illness prevention, and wellness protection, clinical evaluation and diagnosis, immediate and emergency care, treatment and rehabilitation, and organization and professional health and well-being. And on a daily basis, athletic trainers work in all 5 of these domains. Athletic trainers can be found on the field at high schools, colleges. They can also be in any of the branches of the United States military. They can work in hospitals, not only in the clinics and hospitals, but in the operating room as well. They can be assistants in physical therapy clinics, working on rehabilitation, as well as with any professional sports team. And these are just a few. Athletic trainers can be in a number of different settings.
All right, so now that we know a little bit about what an athletic trainer is and where they can be found, a little bit more about what a concussion is. So a concussion is a traumatic brain injury, Tori. And concussions usually occur from a hit to either the body. Go back. Sorry. Yes, no problem. Concussions can occur to either hit to the body or the head. And what happens is the brain, as you can see in this description here, rocks in the skull and hits the sides of the skull, which causes the cascade that is a concussion. a misconception is that an individual needs to lose consciousness in order to have a concussion. That is not the case. You do not need to lose consciousness in order to be concussed. So physiologically, what happens when you have a concussion? So it's considered as a neurometabolic cascade. And this is because there are two components. So ionically, there are changes that are happening within the brain. In order for nerves to send impulses, they require a very specific ionic balance. And what happens with a concussion is there is diffuse depolarization, and that causes the ions to become imbalanced. So when the ions become imbalanced. So when the nerves try and send the impulse, the message essentially gets muddied and it's not transported as well as it should be. And then there's also a mass release of neurotransmitters. Neurotransmitters are important for the nerves when it comes from transporting message from one nerve cell to the next. So when there's a mass release of those neurotransmitters, once again, the message gets muddied and it's less clear. Then secondary, there is a metabolic component. So what is happening is the brain identifies that there is an issue and it immediately wants to return to homeostasis. The body always wants to be in balance. So it causes an increase in the energy demand because the body needs energy to fix the problem. But simultaneously, what is happening is there's a decrease in cerebral blood flow. This means that the brain is not getting the oxygen that it needs. So now there's an increase in demand and a decrease in supply. And this lack of oxygen to the brain causes a secondary issue in and of itself. And so essentially what is happening is this right here. There's a lot of chaos in the brain. Michael Scott is trying to keep everyone calm, but his own demeanor is almost making more of a problem. And we like to use the analogy of a snow globe because when the snow globe has not been shaken, the image is very clear. But when it has been shaken up, you can't see as clearly. And that's exactly what's happening with a concussion, where the image or the messages just are not being received and they're not being transported as clearly as they should. And it's also important to note that concussions are a functional injury. They are not a structural injury. So you will not see a concussion on an MRI or a CT scan. And similarly, when you shake up a snow globe, you don't see cracks in the globe. It is just a functional injury where things just aren't functioning as they should. So there are a number of different signs and symptoms of a concussion. So the signs of a concussion are things that an outside person can see. So some of the examples here are loss of consciousness, disorientation, so the athlete or the subject doesn't know who they are or where they are. Incoherent speech could be slurring of words, or could be they just simply don't make any sense. So there's a bunch of signs of concussions, and then there's also a bunch of symptoms of a concussion, and the symptoms are what the individual would experience. So headache, difficulty concentrating, sensitivity to light. And being able to have someone who's aware of all of these signs and symptoms, such as an athletic trainer on the field, is incredibly important for identifying and catching them quickly. Before we move on, we just wanted to make sure that everyone has a good understanding of what a concussion is based off that explanation. If you have any questions about what a concussion is, please ask them now, because having that foundation is going to be important moving forward. Okay, fabulous. So next, a little bit about what a concussion evaluation looks like. So whenever we have an injury evaluation, we typically break that injury evaluation up into different parts. And these separate parts are consistent across any injury, whether it be the ankle, the hand, or the brain. So the subjective section is what the athlete is going to tell you about their injury. So go ahead. So this will include, for a concussion, it'll include the mechanism of injury. So what happened? Where did the athlete get hit? How did they get hit? What did they get hit with? Their previous history of both concussions. So how many concussions have you had? When was the most recent one? And then relevant medical conditions such as depression, anxiety, ADD, ADHD, and more, and then also medication use. The objective section is what you will test or what you will see. So this will include whatever you observe, and those are those signs that I was talking about, which can be the stumbling, the slurring of the words, the athlete being confused, and then as well as multiple different tests, such as our graded symptom checklist, orientation test, memory test, and so on. There is a bunch of different components to the concussion evaluation, and hitting every single one of them is incredibly important. And then next is the assessment and plan. So the assessment part is the diagnosis and the differential diagnosis. So what do we think it is? And then what else could it be? As athletic trainers, we are not, we don't have a ton of resources in regards to imaging. So we can never really be 100% sure. So we always have to keep other things in the back of our head through that differential diagnosis. And then our plan. Our plan is going to include what did we do that night or that day, that immediate care. What are our follow-up instructions? Is the athlete going to come see us? Are they going to the ER? Are they going to their primary care physician? Their home education would be things to avoid, the fact that they should sleep as much as possible and things like that. And then their long-term treatment plan. So what are we going to do over the course of the next few days, few weeks, maybe even months? Why is this so important? Why do we want to have a really thorough concussion evaluation, and why do we need athletic trainers to be basically on their game? It can be really important for identifying life and limb threatening conditions. One of those being, or two of them technically, being different types of brain bleeds. We have an epidural and a subdural hematoma. These conditions will appear very similarly to a concussion, and there are some red flags that we look out for when we do a concussion evaluation to make sure that there's not something big and bad happening beneath the surface. And then also cervical spine fractures are things we keep in the back of our head, because a lot of the times concussions happen to a hit to the head. And when they hit their head, there's usually a neck involvement. So we want to be able to identify these conditions incredibly quickly and manage them immediately, so that way the athlete has the best outcome. And then it's important because being able to immediately treat a concussion can really help with long-term prognosis. So removing an athlete from physical activity and instructing them to have physical and cognitive rest for the first 24 to 48 hours has been shown to help improve long-term prognoses. Athletes who either return to play or who do not get that rest tend to have more prolonged symptoms. And then also educating the athlete on the red flags and the do's and don'ts can help with identifying these issues that I mentioned above, because one of the brain bleeds, the subdural hematoma, is a venous bleed. It bleeds slowly, so it might not show up immediately while I'm doing the evaluation, and being able to provide that information is going to be incredibly important. Does anybody have any questions on the concussion evaluation component? Fabulous. We don't expect you to be able to do a concussion evaluation, but just a general outline of.
I had a question.
Yeah.
Hi. When there's like a saying when someone gets a concussion, like to not let them sleep, is that kind of a myth?
Yeah, that's a great question. So it is kind of a myth, but it's a little not. So the thing is really going to be really based on when the athlete gets concussed and how worried you are about the potential for, say, a brain bleed. Rest is incredibly important for our brain when it comes to healing, but at the same time, we want to be able to make sure that we're watching out for those signs and symptoms. So most of the time, if you're ever really worried about it and it's late at night, we would usually just refer them anyways. But most of the time as well, like if most concussions don't end up with a brain bleed. So if you're handling a generic traditional concussion, you encourage sleep regardless of when they get hit. But if you're at all worried about that, that's when you want them to be monitored while they're sleeping. Good question. All right, moving on. Okay, So our research specifically looks at concussion documentation. So why do we even care about documentation in the first place? Well, first, it's a medical industry standard. Whenever you go to the doctor, that doctor is going to be writing up a detailed outline of the encounter. And that way you have a very complete and comprehensive medical history on file. This allows for a continuity of care. So if you go see another doctor, they know exactly what you've already done, what you haven't done, and a little bit more information about where we should go forward with that. It also helps demonstrating value specifically with athletic trainers, because we're a relatively new profession and people don't recognize how much we help to save people money and how much we just help athletes in general. So having a documentation of everything that you've done over the course of the year, people can see just how impactful you are. And then also a legal litigation defense. God forbid there's a lawsuit, you have a detailed record of what happened. So that way, in case anyone is claiming otherwise, you can say, hey, look right here. All right. So we decided to focus in on concussion specifically because there has been a mass influx of information within the last, 8 to 10 years. These that you see on the screen right now are just some of the examples of all of the information that has come out. And it may not seem like a lot, but that's a lot. And there's been a lot of changes as to how we assess concussions and how we manage them, just based off that one question that we had right then, because as you saw, that used to be the standard and it's no longer the standard. So it's really no surprise that athletic trainers are just having a hard time keeping up. One group found that nearly half of athletic trainers were not using a 3-domain minimum concussion assessment battery, which included symptom scores, a balance assessment, and a neurocognitive assessment. Now, if you can remember back to the slide of the objective assessment with the guy with a little magnifying glass, all of those things that were listed out are all the different components of an evaluation, of the physical evaluation. And basically what this study is saying is that athletic trainers weren't even doing 3 of that list. So there's definitely a lacking when it comes to the assessment and management practices. There's also a lack in the quality of documentation. One group in particular was using concussion documentation to analyze concussion assessment and treatment characteristics, and they found that a lot of their data was essentially missing. And they stated directly in their article that the study had reinforced the need for a standardized approach to concussion assessment and appropriate documentation practices. And then another group had looked at secondary school athletic trainers and asked them what they felt was some of the limitations to documentation. And they felt that a lack of education regarding documentation strategies, as well as an uncertainty of what to document, were the primary reasons why behind some of these issues, which is all to say that concussion evaluations and documentations are just not quite there yet. So implications for improvement. How do we improve? Let's start off by asking, and that's what this group did. They asked secondary school athletic trainers, where can we improve? How can we improve? What do you guys need in order to improve your documentation? And they said that education on documentation strategies, as well as education on what should be included in documentation, could be really great. And that's essentially what we wanted to do with this. So the purpose of this study is to develop, validate, and pilot a novel tool to audit completeness of initial concussion documentation. For the purpose of this study, we operationally define completeness as the initial documentation that has all the recommended components from best practices on concussion documentation. We also operationally define initial concussion documentation to include all of the encounters from the same day an athlete reports an injury to the healthcare providers that is ultimately determined to be a concussion.
Okay, so the methods section had 3 main components that we went through, as you could kind of tell from our purpose statement. So first, we had the instrument development phase. Next, we had to validate our tool as well as check for reliability. So validation is, does the instrument measure what we want it to measure? And reliability is, does the instrument measure consistently? So with these little target illustrations, in the first one, all the targets are together, but they're not on the bullseye. So that is reliable. It consistently got the targets in the same area, but it didn't get it where it was supposed to, so it's not valid. In the middle two bullseyes, you can see they're kind of all over the place, and so those aren't reliable or valid. And then in the last one with the dart on it, they're all in the bullseye and they're all close together. So for this one, it got where it was supposed to get, so it was valid, and then they're all close together and it measured consistently, so that's reliable. So for the instrument development, there were 3 parts to this. We did a thorough literature search to see what was out there and how we were going to develop this tool. We figured out what type of grading scale we were going to use, and then we created the tool through SurveyMonkey. So for the development of the instrument, we use this 4-step process where in the first step, that was the planning step, and this is where we did all of our literature searching. We created the definitions that we wanted to use, as well as our purpose statement and our research question. In the construction phase, this is where we picked what items would be included in the tool, and we had all of those items reviewed by experts, which I'll go over that in a moment. And then we took that tool that was reviewed by experts, and our group of researchers did a pilot test, and based on actually using the tool, we made the appropriate changes. And then last, once we had experts look at it, we pilot tested it, the final tool was created and we created a valid tool. So through our literature search, as Cassie stated, we looked at best practice guidelines for documentation and what should be included in any type of documentation note. And then we looked for best practices regarding concussions. And so through the National Athletic Trainers Association, they have a position statement, which is best practices for athletic trainers to follow, as well as every 4 years, a group of experts meet, and we use the 5th meeting or international conference on concussion in sport held in Berlin, and that was in 2016. A 2020 version was supposed to occur, but because of COVID, some things happened. So this is the most up-to-date consensus statement, and then we use the most up-to-date position statement, as well as the NCAA has tons of concussion resources and a concussion checklist, things like that, that we utilized as well. And so essentially we came up with these 16 important topics from a combination of those 3 best practice resources. And we broke it into categories of history, presentation, physical exam, and assessment and plan. And this was similar, the format here is similar to what Cassie was talking about with the subjective, objective assessment and plan, because athletic trainers are already used to that format. And so the notes seem to flow in this order. So next we had to pick what type of grading scale we were going to use, and it made most sense to us to use a 2, 1, and 0 point scale. Our hopes in all of this is to improve documentation among athletic trainers. So if we just used a 1, it was their scale, and 0, it wasn't their scale, you don't really have room for improvements if it was sort of there. So we used 2, it was there, it was in the note. 1, it was sort of in the note, and it might have been partial credit essentially, and then 0, it was completely missing. And then this is an example of one question from the tool that we created. So all the questions were laid out in this format where it listed the question. So is the mechanism of injury documented? It gave some examples to give the person some context of what exactly that question is looking for. And then the answers are, here's the 2-point answers listed first, and then the 1-point answer, and then the 0-point answer. And that was consistent throughout the whole tool. So the next part was the validation. So for a reminder, validity is, does the tool measure what we want it to measure? And that was the bullseye where it was all in the middle. That was the validity. So we had 2 types of validity. We had expert evaluation of the CDAT, which is our concussion documentation audit tool that we created. And then we took the CDAT answers and compared that with expert subjective assessment of looking at the CDAT. And I'll go through those in a moment. So when you're trying to see if something is valid, you typically compare it to the gold standard. So if somebody had a broken bone, they would typically get an X-ray to see if it was broken. And say I told you that there's this new app on your phone where you could take a picture of your bone to see if it was broken. Well, we would need to test that app to an X-ray, which is the gold standard, to see if it matches up. If the phone says it's broken and the X-ray, which is the gold standard, says it's broken, then the app probably is a valid tool. And so in our case, there was no tool, gold standard tool out there that said if a concussion note was complete or not. So when there isn't a gold standard, that's when you use experts. So in that same broken bone case, if there wasn't X-rays, you'd have an expert like a doctor try to evaluate it, see what they think. So our panel of experts that we used 5 experts, and they had a diverse background, but they were specifically experts in concussions. And then for our subjective assessment, we used a different panel of experts, and these 2 experts looked at all the notes that we got, and they rated them as either very good, good, fair, or poor, and those equaled a percentage. So if it was very good, it was 100%, good 75, fair 50, poor 25%. So next was reliability, and we tested for inter-rater reliability as well as intra-rater reliability. So inter-rater reliability is, does the tool measure consistently between people? So if rater 1, rater 2, and rater 3 each rate the note, are they going to be consistent between the 3 of them? And just a reminder, reliability is that you're in the same area. You're not on the target, but you're all getting the same results. And then intra-rater reliability is, does the tool measure consistently between the same person? So if rater 1 rates it the first time and then rater 1 rates it a week later, is it going to be the same? And then lastly, we did an inter-rater agreement analysis of each question. So this we looked at, does rater 1 rate the same as rater 2 for question 1? Does rater 1 rate the same as rater 3 for question 1 through all of our questions in the CDAT? So how we did this was we had 53 de-identified notes that were from athletic trainers that had done previous concussions from a local high school and a local college. And we rated the notes we rated all 53 notes, and then a week later, we rated all 53 notes again for intra-rater reliability. And this was for a memory component. So we wanted to see that the first time we rated it, we could rate it the same as the second time we rated it. And we wanted enough time in between those 2 that we wouldn't remember how we rated it the first time, and we would actually just rate the note how we're supposed to. So all of the statistical analysis that we ran for the study, for reliability, we did the question level agreement analysis. So that was between rater 1 and rater 2, rater 1 and rater 3, rater 2 and 3 for each question. And then we did a two-way random interclass correlation for each of the sections. And then for validity, we did note level agreement analysis, looking to see that the scores we got on the CDAT were the same as the experts, how they rated it on that 100, 75, 50, and 25% scale. And then we did a Pearson correlation to see if those same scores to the same CDAT scores to the subjective expert assessment was correlated. So some terms here, correlation is similarities. So in the summertime, when the weather's hot, ice cream sales increase. Also in the summertime, when the weather's hot, there's more shark attacks. But an increase in ice cream sales doesn't mean that there's going to be more shark attacks. Those are just correlated. They don't cause each other. One doesn't cause the other. So we're into the results. So this was our inter-rater reliability across sections. So this was rater 1, rater 2, and rater 3. So along the x-axis here, we have each of the sections: history, presentation, physical exam, assessment and plan, and total. And then along the y-axis is the percent out of 100. And then the navy bar in the graph is rater 1. The light green bar is rater 2, and the gray bar is rater 3. And so here we're looking for which one out of all of this had the most variability. And so presentation, we want these all to be equal. And this has a lot of variability. And the one that is the most equal is the total. Those bars, rater 1 and rater 2 are exactly equal, and then 3 is pretty close. And so the numbers that correlate to this are the ICC values. As you can see, the 0.773 here relate to acceptability. So how acceptable is that variance in the reliability? So the history, presentation, assessment, and plan are all acceptable. Physical exam is a little bit better and it's good. And then the total here was excellent. So the intra-rater reliability, and this is for rater 1, the first time versus the second time rater 1. So again, on the x-axis, we have the history, presentation, physical exam, assessment and plan, and total. And along the y-axis, we have the percent out of 100. And on this one, the history had the most variance. Presentation was good. And then physical exam, assessment and plan, and total had excellent reliability between rating it the first time and rating it the second time. So there was not a lot of variance there. And then inter-rater reliability for rater 2 across sections. This is the same as rater 1, but just for rater 2. Their history, presentation, and assessment and plan were all in the good range. And then physical exam and total were excellent. They rated those similarly for each. And then this is for rater 3 across sections, and same with rater 2. Their history, presentation, and assessment and plan were in the good range, and physical exam and total were excellent. So now agreement is looking at differences. So the difference between the smallest egg here and the next size up isn't that much, and you might not be able to notice if they were on opposite sides of the screen that they were that much different. But the smallest egg and the biggest egg, there's a big difference there, and you'd probably be able to notice. So here we have question agreement. So this is where we looked to see with rater 1 to rater 2, rater 2 to 3, and 1 to 3, the differences between all of the questions. And so the p-value here means that we want the p-value to be greater than 0.05. And then we want the mean difference to be as close to 0 as possible. And we want the 95% confidence interval to be narrow and to cross 0. And so for questions 6, 7, and 35, those were really good agreement. So the p-value is a lot greater than 0.05. The mean difference is 0. And this is a very narrow confidence interval, as well as it crosses 0. 7 had so slim variability that what the stats app we were using didn't even give out numbers because there was no variability. For 5 and 30, these questions had poor agreement. And so the p-value, as you can see, is not greater than 0.05. The mean difference is far from 0. And the 95% confidence interval is large, and it does not cross 0. Both of those numbers are negative. And then lastly, a few questions with some okay agreement. The p-value is still larger than 0.05, but not that much larger. The mean difference is still close to 0, and the 95% confidence interval is narrow, and on some of these it crosses 0, and some of them it doesn't. So next is the validity results. And so this is where we looked at how the CDAT scored compared to how our two experts that graded it 150 or 175, 50, 25% graded those same notes. And so for agreement, there was poor agreement. So when we audited the notes and they got a 50, the experts should have also got 50, but that was not the case. But there was a correlation. So as the notes were rated better on the CDAT, they were also rated better on the subjective scores. But as you can see here, if you look at some of the dots, they're not lining up exactly, and the line also is steeper because the experts scored a lot higher than they actually scored when using the CDAT.
All right, so the discussion. Click. Thank you. So that was a lot that you were just, provided, a lot of numbers, a lot of concepts, and it can definitely be a little overwhelming. It was overwhelming for us too. But what all that was saying is essentially that, click, we were successful. We successfully created a tool, we successfully validated it, and we successfully established reliability for something to audit the completeness of initial concussion documentation. So let's talk a little bit more about that inter-rater reliability. We saw a lot of numbers, but what do they mean and why are they like that? So across the board, the values were pretty good. All of the values range from acceptable to excellent, which is really, really great. We were not mad about it, but there's always room for improvement. So when we looked at inter-rater reliability, there were 3 components that fell within the acceptable range. The first one, for the history section, one of the possible reasons why this section was a little lower than some of the other sections might have been because of the injury date. So while we were auditing the notes, one of the questions asks about when the injury occurred and if that's documented. One of the things that we noticed was that very often the injury date or when the injury occurred was not documented within the body of the note. Rather, it was kind of up in the corner. So one of the raters may have noticed that and said, yes, this injury date is there. But one of the other raters may have not noticed that and said, no, the injury date is not there. So that resulted in some variability between raters for the answer to that question. For the presentation section, there was a little bit more variability just in general to these questions. So for example, one of the questions asks about, is there any observations on like the athlete's gait and balance? And so one of the notes said that the athlete was able to walk into the athletic training room under their own power. But this doesn't give us any information about, was the athlete stumbling? Were they shuffling? Were they acting normally and walking normally? Or were they just simply, they were not assisted into the athletic training room? So this lack of this increase in variability caused one person to say, well, they did mention walking. That should get a check. But another person says, yeah, they mentioned walking, but they didn't really provide any detail. So this doesn't get full credit. This only gets partial credit. So there, once again, there were some issues there across the board. And then for the assessment and plan section, we noticed that a number of the notes documented providing home instructions to the athlete. Now in our assessment and plan section, we ask about whether or not the things to avoid were educated to the athlete, as well as what the red flags they should look out for. When someone documents home instructions, we don't know whether or not that only includes things to avoid, that only includes the red flags, or that includes both. And when discussing it further after all of the data collection had been completed, it had come up that, well, one rater was giving credit for both, while one rater was only giving credit for one of them. So that's where some variability happened there, resulting in some of the lower ICC scores. Now looking at intra-rater reliability, once again, across the board, the numbers were good. There was only one section for intra-rater reliability for rater 1 in the history section that fell within the acceptable range. Otherwise, it was all good or excellent, which is fabulous. Now, once again, things can always be better. So let's talk about it. So for the history section, we're going right back to that injury date. Click. Same thing where, during the first round of auditing, the rater may not have noticed that the injury date was in the upper right-hand corner. But the second round of auditing, they may have noticed it and started then scoring it appropriately. So that's why there may have been some issues in the history section within each rater's audit. And then for the presentation section, one of the components was that while we were doing the notes, we noticed that some of the symptom scores were on a separate page. So some notes had said, okay, they had a symptom score of say 65, or they had, a headache of 3 out of 6, dizziness of 2 out of 6, so on. But some of them only mentioned that symptoms were done or something like that, where it wasn't clear. And so what was not noticed was that there was a separate page that the symptom scores were actually documented on. And it wasn't until after the audit of that note was done that it became, it was realized that that's where these symptom scores were. So that may have led to it. And then as well, this section, like I mentioned earlier, just has a little bit more subjectivity. It's a little bit more variability where it's more, opinion based in a way, rather than cut and dry of, yes, this is there, no, it's not. And then for the question agreement, we had 36 questions, and overall 34 of them either had good agreement or moderate agreement. So we just provided some examples. The first one being question number 6, are concussion-related medical conditions or lack thereof documented? So if it was not said that the athlete does have a history of ADHD, or there's no relevant medical conditions documented, though that was very cut and dry of yes or no, it's documented. Question 28, looking at are the results of a central neurological assessment documented, essentially cranial nerves. And then question number 35, is a clinical impression documented? And then what all 3 of these show is that there's just a little less subjectivity. It's a little bit more, yes, this was there, no, it was not. Next. There was, however, 2 questions that had poor agreement. And we are going back to question number 5. Is there documentation of when the injury occurred? That injury date. It got us on all components of this reliability. Once again, just the fact that the date was not in the body of the note, people noticed it later, people noticed it earlier, and so there was just a lot more variability with that answer. And then question 30, are the results of a neurocognitive assessment documented? So one of the issues that we saw with this, or the reason why we think there was an issue with this, is that a neurocognitive assessment actually includes a lot of different components. So some of the examples that we show is reaction timing, decision making, visual, verbal memory, but it actually includes more than just that. And all of our examples are just some. It's not comprehensive and conclusive. So you can have other things that satisfy the question. Click. And one of the things that was discussed is concentration. Concentration can be considered part of the neurocognitive assessment. However, it can also be considered a part of a mental status exam. So some of the raters provided credit when it was documented that concentration was done for a neurocognitive assessment, but then some of them didn't provide credit for that. So once again, there was an issue with agreement across that question as well. Now for the expert subjective assessment, we noticed that the CDAT scores were approximately 14% lower than the expert subjective assessment scores. What we know is that the CDAT scores are based in best practices, so they are valid. Not only have we used the best practices and the best practices to create this tool, but we've also used experts to agree that everything that should be included is included. What we also know is that current practices don't match best practices. So it's safe to appreciate that the expert subjective assessment was likely overestimating the documentation. The experts were using their clinical practice to make their decisions. And if their clinical practice was not up to the best practices, it makes sense that they might be overestimating the documentation when compared to the CDAT scores. But it does support the need for a more streamlined approach to concussion evaluations if even experts are not quite up to par yet. We also saw that there was a significant correlation, as Tori mentioned. As the expert subjective assessment increased, the CDAT scores also increased. So this supports the validity of the CDAT in that we're trending in the right direction. So the information is there. It's just there's just a mismatch between current clinical practice and best practice. So now we have this tool. What do we want to use it for? We just created it to help with quality improvement. So we thought that it would be great to provide objective measures for existing documentation. So athletic trainers can go back to their previous documentation and score their notes and see where things might be missing. And we broke it down into sections, so that way the athletic trainers can appreciate where they may need to focus more of their energy when improving their documentation. And then as well, we wanted to use it as a learning apparatus for students that are coming into the field. It can be used as a rubric essentially for future documentation and an outline. And I know that, at least personally, through my experience with creating the CDAT and using it, every time I have a concussion, I pull up the CDAT to make sure that I am hitting all the points, because there's a lot of components in it. There's 34 questions, and that's a lot of things to remember when you're in the heat of the moment, or when someone is sitting on a table in front of you and you are trying to make them feel comfortable while also, attacking every topic that you need to. And then, like every research project, there were some limitations, and these limitations are just things that, we need to consider, and we need to make sure we are appreciating, that prevent the data from being perfect, I guess, for lack of a better explanation. So particularly for us, we had to appreciate that concussion documentation does not necessarily equate to concussion evaluation. We use documentation as a proxy for evaluation, but it's also possible that things could have been done in the evaluation that simply were not documented. So it's not necessarily exactly the same, but it's correlated very, very similarly. And overall, we wanted to, through improving documentation, we hope to improve the evaluation processes. We also had issues with missing documentation. So there were instances while we were looking and reading through the notes that they had mentioned a test was completed, but there were no results to that test. And we knew that that test had to be documented somewhere, but it just wasn't provided to us. So we had to make decisions about whether or not an individual would get credit for that test or not. And so we did have the initial note, but we didn't have the supporting documents, which, led us to, realizing that moving forward, we need to make sure we're getting all the documentation. Then we also had a narrow sample, but it was simply because it was a convenient sample. It was a huge bite to just create the tool. So we wanted to make sure that we had a good foundation before moving on to a broader sample. But that being said, we couldn't use the results of this sample to extrapolate to larger samples or generalize to, all of the secondary school setting. So that's something, once again, we'll be looking forward in the future. And then there was a little bit of rater bias. So as someone who helped create the tool, when we were using the tool, we had an understanding or a better understanding of what each question was asking for and what each question was looking for. But if a coworker of mine who has never seen the tool in their life decides to use the tool, it may result in a different set of results, essentially. So it's something that we should consider moving forward to that, we need to make sure that not only is it a good tool when it's used by people who are oriented to the tool, but it's also a good tool when used by people who have never seen it before. So in conclusion, our mission was accomplished. We set out to create a tool that was valid and reliable, and that is what we did. And while there are, of course, there's always room for improvement, we're pretty happy with the foundation that we set. And when moving forward, as I kind of touched upon already, we hope to look at a broader sample of notes. We hope to look at complete notes where we have that missing documentation as part of it. And we hope to utilize some unbiased raters to see just how good and how applicable our tool is to the general population and to the clinicians that will be working with it one day. And yeah, any questions? Oh, I know I saw some questions as we went along, but. All right, so I guess we'll jump into the questions that were in the chat. Tori, you want to go back and forth? You want to go with the first one?
Sure.
So the question is, why do coaches require a concussion computer training before starting the season? I find it difficult. If someone already has a learning disability, then how could they evaluate them? That's a great question.
So if the coach has learning disability, is that the question?
No, why do the coaches require a concussion testing, like the baseline concussion testing before you start playing sports?
Okay, so at the college level, a lot of times, for the most part, athletic trainers are required to be where athletes are participating, but at the high school level, a lot of times athletes are with just the coach at practice, at the game, just with the coach. So for the coach to be able to know the signs and symptoms to look out for, to be able to know how to respond to a concussion and not put the athlete back in. There's actually research that's been done that when coaches do take a training session, they are more likely to respond to concussion injuries and know how to identify them. So it's very important, especially when there's not an athletic trainer around and the athletes are just with their coach.
In the event that someone does have a learning disability, so when you do, when an athlete is starting to do a contact or collision sport, we do a baseline test on them. And that gives us an idea of how their brain is functioning without any kind of injury. And then we have something to compare it to if they do have an injury. And this can be applicable to individuals with learning disabilities. If anything, it's more important for those individuals to have that baseline because even though like right now they're moving away from baseline testing for some of the neurocognitive testing because of the fact that we have so much data on it. We have norms, so we don't necessarily need your baseline because we know what normal should look like. But if an individual has a learning disability, it's almost more important for them to have a baseline test because they might not correlate well to the norms, and we need to know what their normal is. But either way, whenever we're evaluating them, we're comparing it to their baseline. Randall says, do you think there might be worry about the implications of the study, such as how damaging these sports might be to an individual? I worry about the implications of the study. I think I'm missing something here.
I think he's asking sort of about the whole idea of sports and the risk of concussion. And is this sort of highlighting those risks? And are you worried that it's sort of giving the impression that, you know, concussions, and Randall, feel free to correct me if I'm not interpreting your question correctly, but, you know, do you worry about the repercussions in terms of people really drawing attention to the fact of the damage and how many people are being concussed?
Yeah, that's about right. What I was thinking.
Yeah, so I think that the more we shed light on concussions, the better. Concussions are very much one of those things that goes undiagnosed, or people kind of just brush it off because sometimes it's the culture of the sport, especially in football. They say, hey, you just got your bell rung and things like that. But the more we educate on the importance of concussions, the more we educate on the signs and symptoms, the more that people are going to be able to identify them, and people are going to understand how important they are and how important they are to catch quickly and to manage immediately. So hopefully the more that concussions are becoming highlighted, the more that, you know, they will be taken seriously. Let me know if that did not answer your question.
The next question is, do you see yourself conducting more research projects such as this one in the future to continue adding to the data in the field? And if so, is there anything you would do differently / the same? So the residents that took over for Cassie and I, so the 2021-22 residents, are continuing with this research, and some of the things that we found, such as the kind of like what we talked about, we're using raters that didn't create the tool. I'm not a part of it. They're using raters that didn't create the tool. They made changes to some of those questions and are ensuring that complete documentation is used. And so some of the variability that we saw in the questions with the rater's interpretation of the question was fixed. And then future research, I'm currently a grad student and I'm doing research on concussed athletes experiencing symptoms of depression, and I'm hoping to do a research study on that. So adding to more concussion data in the field, hopefully.
I'm not doing research right now, but I might be doing it in the future. You never know. The next one is, if you have a learning disability and do get a concussion, can it make the disability worse / different? That's a great question. I don't think that it would necessarily make the disability worse. truthfully, this is just based off of the knowledge that I have, and I would want to look more into some of the other disabilities. But I know that one thing that we always screen for is, does the athlete have a relevant a history of ADD or ADHD? And it's not necessarily that that the concussion will make ADHD or ADD worse. It's more that the presence of that diagnosis has been linked to prolonged issues with a concussion. So I believe it's on average, it takes about 2 weeks from the point of contact or the hit to when the athlete is cleared to play after allowing the symptoms to resolve and then going through a concussion return to play protocol. But, for someone who has a history of ADD or ADHD, it may be 3 weeks, it may be 4 weeks, it may be even longer. They just have an increased risk of that. It doesn't necessarily mean that it's going to be longer, but it's something we always screen for and we keep in the back of our mind. I would be really interested in looking into things like dyslexia or other sort of learning disabilities and seeing how those are impacted. I'm sure that there is a component of just kind of the negative cycle that is a concussion, because when you're concussed, it makes it difficult to concentrate. So, or it makes it difficult to process things. So it might just be not necessarily that the learning disability is getting worse, but rather the mental component of being frustrated with learning might be more of an issue there. But it's definitely a good question, and I'd be interested in looking into that further. And then what was our research question? That is a great question. I might be able to tell you exactly. We changed it 20 times because that's how research works. There's just a lot of edits, and you start with one thing and then you realize that, hey, this is better. So I know we have it somewhere in here. And of course, that's the last question, so we can't.
Does anyone else have questions? Oh.
I have a quick question. So thinking about using this tool on other populations, are there any populations that you would change questions in terms of, I don't know, type of sport versus age, or anything that would lead to a need to change these questions at all?
Yeah, that's a good question. I think that one of the things that we addressed already was the fact that this was looking at the initial concussion documentation, and certainly we did discuss that when you're doing an initial concussion documentation or initial concussion evaluation, the on-field evaluation versus the in the clinic evaluation do look different, which is why we tried to mitigate that by operationally defining initial concussion documentation to be all of the events within I think it's the 24 hours or the time that you're with your healthcare provider. So that way, if you just get off the field and you're doing a sideline assessment and then you go separately into the clinic, those are not two separate evaluations, they're combined into one. But I think that a lot of it would have a lot of crossover regardless of population. Because the only population I can think of that would really cause any kind of a difference would be the child population, but it's not necessarily a difference of what you're assessing rather than how you go about assessing it, because you're working with kids who, may not know where they are because their parent just drove them. You need to know, okay, are you before lunchtime or after lunchtime? And get different orientation questions like that. So we had another question. I
can answer Lauren's question real quick.
Okay.
So Cassie and I, and also one other person from our research team, were the raters. And once data collection was done, we met and talked about those areas where improvements could be made just based on rating the tool, rating it with the survey. And then once we actually got our results, in our statistics and things like that, we had another meeting to talk about areas and for them to improve the survey. So yes, we did do that. And then Rachel's question. Cassie, do you understand that? I might
Yeah,
need
I think so.
clarification.
I think she's just, I mean, if you look just at the question, how do you think outreach and training should be done on concussion information for various levels of education and even sports? So if, clarify if I'm wrong, but essentially how should we go about educating our coaches and educating our parents across sports and across levels of education? And I think that luckily, for the most part, a concussion is a concussion, regardless of whether or not you got it in the NFL or if you got it as a middle school athlete. So the actual education part doesn't, it doesn't change all that much across different levels of, ages or education, or even across sports, because if you get a hit in a football game or you get a hit in a field hockey game, it's all going to be treated the same way. I think what's just important is educating on what are the signs and symptoms to look out for, and that we have a mantra, I guess you could say, of it's better to be safe than sorry. If there's any doubt, sit them out. So concussions are one of those things where that first 24 hours and the immediate treatment is incredibly important. So really hammering that home of saying, hey, look, these are the signs and symptoms of concussion. If you have any doubt whether or not an athlete is concussed, it is much better to have them miss half a game than have them struggle with a concussion for months on end. And this can be done in a number of different ways. It can be done through videos, it can be done through pamphlets, it can be done through, sitting down and having conversations with them. So it's just about whatever works best for you. And we are clarifying, is the coaches not understanding? So how do coaches get trained properly? Yeah.
There are a bunch of coaching classes that coaches should take. I mean, if you're in high school, you could go to the athletic director and have a conversation with them about it. But I would say coaching classes, videos online, going in person, things like that. I don't know if you had something else, Cassie.
No, I mean, I think you hit it. I think that at different levels, it might be required. I'm not entirely sure what the requirements are for the coaches, truthfully. I know that, as athletic trainers, we do our best to educate. And I think a lot of the times, no matter how many classes that a coach goes to, I feel as though just like everyone who learns through experience, it's when a coach has an athlete that has a concussion and sees it for the first time and they actually have to handle it, where they learn the most. So, I mean, of course, there are plenty of different concussion training videos and classes out there. And we, of course, highly encourage that anyone who's going to be working with the physically active population should educate themselves on concussions. But that being said, if you are working with the physically active population, there's a good, especially contact or collision sports, there's a good chance that you're going to encounter it. And I feel like you pick it up pretty quick from there. But I mean, it's more important for the coaches that don't have a medical personnel right there to be able to identify these issues and to identify concussions, to know more about it. And so, we obviously strongly encourage that anyone who's working with the physical active population definitely educate themselves on concussion signs and symptoms and what to look out for.
So I'm wondering, just going back to Tori's question, did you have sort of your initial question in one of those beginning slides when you talked about the purpose, maybe?
So we definitely had our purpose statement. I don't know if we had our research question. Wait. Let's see. Nope.
I guess maybe we could think about it in terms of, was your research question, was it specific in terms of the reliability and validity numbers that you were specifically looking for, or was it more based on the development of the tool? I'm not sure if that makes sense, but so, what was the driver of the question? Was it the outcome you were looking for, to reach a certain, reliability and validity, or is it more just, how do we go through this process?
It was essentially to see if we could create, validate, and establish reliability for a novel concussion assessment tool that we created. So it was basically our purpose statement turned into a question.
Yeah.
Yep, that's exactly it.
Great. Any other questions?
I actually didn't hear that. I'm sorry. Can you repeat it for me?
Yeah, so the purpose statement of if we can develop, validate, and establish reliability for a novel concussion documentation audit tool was what we were looking for. That was our research question, if it was possible, if we could do all three of those things.
Thank you.
Mhm.
Great. Well, thank you, everybody. Thanks for joining us. Thank you to our speakers for sharing your wonderful work, really important work. We really appreciate your time and expertise.